Good morning, everybody. Welcome to day 2 of Law 2030. Welcome, everybody here in Pennovation in Philadelphia, and welcome to our global audience who are viewing us online virtually through our live stream. Just a few housekeeping items for our group here. A reminder, those of you seeking CLE credit, you do need to re-register for CLE if you registered yesterday. The front desk can help you out with all of that. We do have extra copies of Vijay Govindarajan's 3-box solution book up front if you'd like to grab a copy if you weren't able yesterday or you weren't able to join us yesterday. We have t-shirts over here in the hallway, so please help yourselves. And this is a sustainable conference, so you should have received a glass water bottle in your bags, and there are refilling stations around the venue. So yesterday, what a day we had. We talked all about what real innovation looks like, some of the challenges in the legal profession, and some of the major shifts happening that we need to think about how we should respond to. Today, we're moving into a new area. So one of the main goals of this initiative is to be truly interdisciplinary in the way that we think about solving problems. And the best way to do that is to hear from people who've solved problems in other disciplines. So all day today, we will learn from others. We'll start the morning with a panel led by our dean of innovators in the healthcare space, who will share with us some of the challenges, successes, and weaknesses in trying to innovate in a very complicated and complex marketplace. After that, we'll hear from flash presenters who will issue 15-minute presentations, and these presenters come from disciplines that are wholly unrelated to the law in many ways, but we can extract lessons from the innovations and the solutions that they've designed to those problems. We'll have a moderated discussion at the lunch break with our flash presenters so that we can delve more deeply into some of the challenges and big wins that they had in creating these solutions. After that, we'll hear from Professor Gary Cazalet at the University of Melbourne from Australia. He'll talk all about how we can use user-centered design as legal professionals to enhance the legal service delivery we provide to our clients. In the background of all of this, our students are right now over at Wharton, on Wharton's campus, working with a real client to walk through the 5 stages of user-centered design to solve a non-legal problem that plagues our profession. And they will be back here in the afternoon to pitch their solutions Shark Tank style and compete to win amazing prizes. And we'll wrap up the day with our advisory board member and president emeritus of Legal Services Corporation, Jim Sandman, who will issue a call to action. At the end of all of this great conversation, where will we go with these ideas? What will we do next? What will our action be? So with all of that, I will turn it over to our dean to get us started.
Thank you. Thanks very much, Jen. And as Jen said, and I appreciate her leadership in structuring this agenda, because today we build on what we did yesterday and take it in some new directions, learn from some colleagues from other fields. So yesterday was mostly, we heard from people from such a wide variety of perspectives and settings working within the law or analyzing the legal profession. Today we have lessons from the healthcare field, from other fields, and bring some students with their new ideas into it later this afternoon. So I'm really excited about today. This panel I'm excited about. It's an area that I've studied through my academic career. I've worked as a lawyer working on healthcare issues and pharmaceutical issues. And I think, and the 3 panelists who I'll introduce briefly in a moment are colleagues here at the university who I really admire for what they've done over their careers and currently in analyzing and shaping change within the healthcare field. Now, what I think, for we lawyers and some of the themes that came up yesterday about the challenges of reforming or changing a field with kind of entrenched professional norms and big institutions. I think when we look to the healthcare field, we would say that, number one, we're not alone in facing those challenges of professional authority, state licensure regimes, deep regulatory barriers perhaps to change, payment and cost issues. So there, I guess another way to put it bluntly for we in the legal profession, when we see what's happened in medicine, there is no excuse from these barriers for thinking about changing our own legal services delivery, because in almost every instant, be it the regulatory burdens, be it professional authority and conflict, it's at least as great in the health field. Now, one major difference that I think all three of our panelists will speak about is the presence of major third-party payers in the healthcare field that generally doesn't exist in the legal field. And so I think one thing all three of our guests will speak to is both the challenges, but maybe the opportunity, the way that payers, both public sector, Medicare, Medicaid, and then private insurers have complicated, but perhaps in some cases helped catalyze change in a way that we don't presently have available in the legal community. So I'll briefly introduce them, but we really want to hear from Ralph and Mary and Roy. So to my immediate left, Ralph Muller has led some of the largest health systems in our country. Very recently left the CEO position after over 15 years leading an $8 billion organization, the University of Pennsylvania Health System, and all of the complexities involved there. And Ralph will speak to over the period 2003 to 2019, so a time of great change in our healthcare system. But before that, he was head of the University of Chicago Hospitals and Health System, and has worked in many other settings, also in the public sector for Massachusetts as Deputy Commissioner for Public Welfare. And he's a member of the National Academies of Medicine, which is kind of the highest honor within medicine, as is our next guest, also a member of the National Academy, Professor Mary Naylor, who is the Marion Ware Professor in Gerontology at the #1 nursing school in the country and the world, the University of Pennsylvania School of Nursing. She's worked on as architect of the transitional care model, which is a care management approach tested and approved by the NIH in clinical trials to improve both the quality of care and efficiency for older adults' experience and health outcomes. She's the recipient of, just a few years ago, of Academy Health's Distinguished Investigator Award, and has worked at the highest levels also of the federal government as a commissioner of the Medicare Payment Advisory Commission, the National Quality Forum, and the Agency for Healthcare Research's Quality and National Advisory Council. So a very eminent expert in academia and in the government. Roy Rosin is the Chief Innovation Officer of this large and complex healthcare institution, Penn Medicine, who is working and has worked with Roy and Mary and colleagues to help redesign the care delivery for hundreds of thousands, maybe millions of patients. Before that, Roy had a distinguished and very innovative career in Silicon Valley and in the tech community, where he was the first vice president for innovation at Intuit, and has advised many startups and Fortune 100 companies on creating a culture of innovation. I think I'll note with one, I think this is the first day all year that, Roy, you've worn a tie, and so this is, and it's one of the few days that I don't. So this, I will note, as we're trying to transition into, this is a phenomenon somebody should write an article or a student note about, where I think it's evocative of an O. Henry story, right, where I don't wear a tie because I think the tech folks are, and then our innovation officer is wearing a tie. So we'll have to work that out next time. But let's get. So I know. This is a tall order, given all the change that you've worked on. But what can we lawyers learn, and what has happened in the healthcare system that you think might be helpful to us? Ralph, I know you're going to lead us off.
Yeah. Thank you, Ted. I'll stand to make it a little easier to project in this beautiful setting. I was saying to Ted, we have a space like this at Penn Medicine, but we don't have wine there, so we have to, an innovation that we have to bring over to Penn Medicine very quickly. Just a glass, yeah. I want to speak about three themes briefly, but Mary and Roy and I decided we'd just give a brief introduction and then get into interaction with all of you. And the first one is really that how much payment drives the organization of medical care. By and large, while we think about all the technology that's going on in healthcare the last 50 years, since really World War II, the great innovation in American healthcare, whether it's in pharmaceuticals and devices and care delivery and so forth. But part of what I've found in the years that I've been doing this, as Ted said, I've been CEO for 35 years, is how much it's really driven by payment as well. Because if the government, as you probably know briefly, roughly half the cost of healthcare in the country are covered by government, which means you and I as taxpayers pay for it through what Medicare and Medicaid program, The other half is provided by private employers like Pern. So what they're willing to pay for, in many ways, shapes what kind of technology is brought in. Now, in recent years, inside our field, we have this kind of jargon of volume versus value. In some ways, and this happens in law as well, just think about an Uber ride versus a ride in a taxi. You know, basically, in the taxi, you have your taxi meter going, then at the end of your ride, you get the kind of bill. Uber does it in advance. And basically, what Medicare especially has tried to do the last 35 years, and really accelerated in the last 6 or 7 under Obamacare, is to pay more on what are called bundles or episodes or procedures. I mean, an easy one for all of you to kind of have in your head is kind of a hip replacement or a knee replacement. By and large, now, we get paid not on how much the surgeon charges and the anesthesiologist and the nurse and the operating room and the rehab. We basically get a payment in advance, let's say $30,000, and then we have to figure out how to divide that among the professional people, among the hospitals, and obviously, if you have had a knee or or hip replaced, anybody in your family, you know, you need to do a little rehab, prehab before, a little rehab afterwards. You may go to a rehab facility. You may need some care at home. It's all in one bundle, an episode. And increasingly what Obamacare tried to do, and it's been mirrored as well in the private market with the big insurers like Blue Cross, et cetera, Aetna, and so forth, is to go more and more towards what are called bundles, as opposed to letting, quote unquote, metaphorically, the taxi meter run. And obviously that's a challenge inside law as well. Now, this started back in 1983, so it's not as if this is when the prospective payment system went to something, those who have any familiarity with medicine, called DRGs. So it's not as if this just started a year or two ago. And the fact that we're sitting here, 37 years later, still trying to implement this tells you change in these big complex institutions is very difficult to secure. Increasingly as well, we're being asked to take risk on a population where we're told, here's a set of patients with heart failure, here's a set of patients with lung cancer, and what can you do and take some risk around those populations, not just procedures, and that is increasingly happening too. Again, it's very difficult to do. Obamacare tried to do this very fully. By and large, the evidence of success is very mixed, meaning some places worked it out, some places did not. We can get into the question and answers after it. Largely that has to do with how doctors and nurses are organized, and they're not as good at learning how to develop those kind of skills. And if you grow people, just like if you grow a law firm, by analogy, with everybody you've kind of trained and socialized, you get a different set of people than when you kind of hire them, or if you have, I used to be in Chicago, as Ted said, if you take the big law firms in Chicago or here in Philadelphia, now they have national and international branches. You know you get a different set of characters when all of a sudden you pick up a law firm in Minneapolis or Houston, as opposed to growing your own. So part of the challenges in healthcare is by and large, how do you put your set of professionals, nurses, doctors together, as opposed to affiliating and amalgamating that. But the simple theme here is, how do you get paid? Often shapes. Again, to go back to my knee and hip replacement, you get paid for the procedure, all the professionals, the 30 days before, the 90 days after, it's all have to be caught inside that bundle. So no matter how much of a kind of taxi meter you run, you're just going to get X. So you have to figure out how to do that. One thing that's happened as well inside healthcare is that we've gotten bigger. There's a lot of consolidation going on. Hospitals have been consolidating. Insurance companies have been consolidating. Everybody's consolidating. This goes back, the kind of theories going back 60, 70 years of kind of countervailing powers. And people, by and large, feel you have to get bigger to negotiate with the insurance company and so forth. Rob Burns and I, who is a colleague of ours at the Wharton's, we've written about this and basically have said it doesn't work. The bigger is not better in healthcare. So it'd be interesting to see, have a conversation where the bigger is better. Meaning it's not better in terms of there are not better outcomes or better cost controls. There's very few economies of scale in healthcare. But what you can do by getting bigger is get better prices, and that's another matter. Second theme is how do you organize professionals? I'll talk more about doctors. My colleague, Mary, is a professor at the nursing school, so we'll go into comparative expertise here. And so one thing that we've had to do is to consider how much do you focus on the geography. For example, Penn, my theory is, those of you who are sports fans, which I am, Penn medicine goes whether there's Phillies fans or Eagles fans. We don't go where there's Yankee fans. Now, why do I say that? By and large, medicine reflects the culture of society. So if you've grown up on the Inquirer versus the New York Times, or SEPTA versus New York Rails, or the department stores here versus Macy's and so forth, that reflects your kind of consideration. it's been very difficult to create national medical groupings. The ones that have tried, Cleveland Clinic and Mayo Clinic, have failed at it. I mean, they won't tell you they failed, but they really have failed at it. If you're going to go to Mayo Clinic or Cleveland Clinic, you're going to Rochester, Minnesota, or Cleveland. You're not going to some branch down in Jacksonville or in Naples, Florida. So basically, and essentially places like us, whether, my old days in Chicago, we divvied up Chicago between the White Sox and the Cubs, Northwestern and Chicago, or when I used to live in Boston, I always knew the dividing line between the New York and Boston medical markets were Hartford, and north of Hartford, they're Red Sox fans, south of Hartford, they're Yankees fans. And I don't mean that facetiously, again, it reflects the medical patterns. So by and large, what we have focused on here is our geography. And that is true around the country, whether you're at Stanford, whether you're at Michigan, whether you're at Houston, Baylor, et cetera, Vanderbilt. The big medical systems focus on geography. The exceptions to that are health companies that really are not integrated groups, but just are holding companies, like the big for-profits. And the other one, more mission-driven, the Catholics have organized themselves nationally, and that's basically a form of income redistribution between the poor inner-city hospitals and the suburban hospitals. So they did it more for that reason. But the care delivery has not changed. So by and large, the elite places, whether they're the Mayos, the Clevelands, the Harvards, the Penns, the Dukes, the Stanford, et cetera, Chicagos, and so forth, they organize themselves geographically. I know your field has gone very much into both national and international kind of affiliation. It has been very difficult to secure the benefits of integration and outcomes. For example, recently, about 2 years ago, Johns Hopkins, one of the elite hospitals in the country, took over a children's hospital down in the Tampa, Clearwater area. Within a year, had a major quality disaster because the doctors here were doing unnecessary surgery, had poor outcomes, so it devastated the Hopkins brand because they didn't have their doctors down there. So it's very unwise to put your name in a field like medicine on places where you can't control the quality, and Hopkins found that out very brutally. Another question is, how big does a group get? Now, as I mentioned earlier, you can think about growing your own, as basic academic medicine often does, or the Mayo and Cleveland's do. When you try to affiliate other groupings, it's very difficult to secure the advantage. Again, as we've written, the quality outcomes and economies of scale really do not exist. You have to then deal with the autonomy of your various subgroupings, whether surgeons or cardiologists or internists or radiologists and so forth, let alone nursing and pharmacy and so forth. So one of the things we have found nationally is it's very hard to really create multi-specialty groups. If you're a Cleveland or Mayo or some of those clinics, and some academics do it more, like the Penns and the Harvards and the Hopkins do it more around creating affiliation groups. But it's very difficult, really, nationally, to create multi-specialty groups unless you grow your own and aggregating people together. So, and again, something for you to consider inside your profession. How much can you really aggregate across subspecialties? And we have found if you grow your own, you can do that. But if you're basically trying to take an independent set of orthopods and link them to a bunch of neurosurgeons, it's very difficult to secure. And the third issue here, and again, Mary will speak more about that, what is the relationship among professionals, doctors, nurses, pharmacists, and so forth? The good news in American healthcare is the public still trusts us. The highest rated professions in the United States by Gallup polls or NORC polls are nurses, doctors, and pharmacists. I remind the doctors that 20 years ago they were at the top of the heap. The nurses have overtaken them. I think the doctors starting to be seen as being too mercantile. That's
one difference between lawyers of our field and yours. It's the trust. Yeah. I've seen those ratings.
You're not down there with members of Congress and used car salesmen.
We'll always have Congress.
There's a lot of room in between. So, but the serious part of that comment is, I tell people, don't blow that trust. Because if you blow that trust in the eyes of the American public, you're going to be treated like Congress and lobbyists and so forth. So it's important for all of us in healthcare to maintain that trust. So my theme is on the organization is you're best off growing your own. If you can't grow your own, you have to do it selectively over a period of time. The notion you can just glom people together in different geographies has not worked inside healthcare. And by and large, if you don't want to have the same quality, like the big for-profit firms like HCA, they're willing to take choice demographies around the country, the Boca Ratons of the world, and the kind of Hinsdales around Chicago, and the main line around here, and base themselves on geography, but they basically don't try to run any kind of common practice after that. So again, very difficult to aggregate in any kind of national scene. And the third theme I want to just go over is the innovation, and Roy will speak a little bit more about that than I have here. And I'll speak about two kinds of access. One is just kind of access to healthcare, and that debate is going on in the primaries right now, with Senator Sanders and Warren talking about Medicare for all, which is a way of getting people insured. By and large, as you know, inside this country, about half of us, as I mentioned, are insured by employer, and then the bulk of the rest of us insured by Medicaid and Medicare. But we still have 30 million people who are not insured, and that's what Sanders and Warren are talking about. And Mr. Trump has not been helpful on that front. But I think the access I want to talk about more today is how are people now getting access to care that may be less expensive. So one of the things you now see around the country, you have CVS's and the Walgreens having walk-in clinics. All of us now carry this great health device called an iPhone, which you can do echocardiograms and do all kinds of monitoring on that, your smartwatch and elsewhere. So what you're seeing is people trying to, since medicine is very expensive, especially in the United States, largely due to pricing, we can get into that later. Since healthcare is so expensive inside the United States, the question is, are there less expensive forms? Now, as I tell, my kids are kind of millennials, and if you tell that generation, you can text your doctor for free every 13 seconds, they're going to do that. Even places like who allow telemedicine with their doctors are now limited to 8 times a month rather than having to do it all the time. The Walgreens and CVS's, they do $49 visits and so forth. By and large, what has happened there, that is added to national healthcare expenditure. It is not substituted for what doctors and nurses do. It's, by and large, if you get a $49 visit, you'll get a $49 visit. That's pretty cheap. Because if you go see one of our doctors, you're not getting away for $49, as you know. So by and large, what's happened in this innovative space is essentially one more add-on to the healthcare system. The aspiration was that it would substitute for what doctors and nurses do, and again, it's been one more kind of add-on. One thing we're trying to do through these watches and iPhones and so forth is, one thing you learn about disease is you have to basically hover over patients. Patients, unfortunately, are not very good at following instructions. They don't do what's always, some things are more difficult, like stopping smoking, but just watching your weight and your blood pressure and so forth. One of Roy's colleagues of mine, we've written about what we call automated hovering, where we text you and remind you constantly. But you see a doctor maybe 2 hours a year. There's other 5,000 hours that you don't see a doctor. So we're increasingly learning how to hover over you to remind you to do things. And now that can be a little creepy and annoying, but by and large, we think in between smoking and dietary control and blood pressure and so forth, it's a good thing to do, and increasingly we're experimenting with that. And the last thing I'll speak about briefly is we're doing a lot of work in terms of accumulating data. One of the things we've developed largely due to the push in Obamacare is electronic health records everywhere. So now when you go to Penn Medicine, other places around the country, almost everything is there right in front of you. You can get it on your iPhone, tells you your allergies, and it tells you your vital signs, it tells you your images and your doctor's notes and nurse's notes. It's all right there. It's all instantaneously. So when you come see one of our doctors, they know exactly what happened the last time you saw us, even if it's 15 seconds ago. So having that information there, we now kind of curate that information so we can start telling inside populations what you're disposed towards, what kind of treatment we can do. So increasingly, we're doing this kind of machine learning of all the information we have on our 6 million patients, and we kind of, it allows us then to kind of titrate and curate what we need to do for you. Now, I've rushed through 30 years of healthcare in about 7, 8 minutes here. We'll be glad to talk about more fully again, but to repeat the themes, how you get paid has an enormous effect on what you do. Secondly, organizing professionals is difficult. The healthcare is the most complex, according to Peter Drucker, the most complex social institution in America. It is just filled with all kinds of different professional groupings, all of which, as Ted said, have their own licensing requirements. How you get those silos to cooperate is a major challenge. And my theory is, at best, you can try to take care of a population in a certain region. It is very difficult to do national health care. And the third theme is, in terms of access, I didn't talk very much about insurance access today. Perhaps we can get into that later, and that's obviously a big issue now in the political debates on the Democratic primary side. But increasingly now, you're seeing more and more innovation going on to try to avoid going to expensive medical institutions by using technology such as smartphones and iWatches and so forth to basically hover over you. Now, probably you're less willing to share your health data with Google than you're willing to share a lot of the things that you do. And so I think there will be some limitations on how much sharing can go on because people don't like sharing their health data for obvious reasons. But increasingly now we have that data on you, and we can use that to help manage and improve your health care.
Thank you.
So I'm delighted to join Ted, Ralph, Roy, and all of you in a conversation about what I think of in terms of important changes in healthcare and the implications for the future of professions, not just healthcare professionals. And I thought I'd just start by providing some context for some of the thoughts that I have. And what are the drivers, key drivers of change, and some very different perspectives on that. One is, as Ralph suggested, that we do have a new consumer emerging over the last couple of decades. Consumers such as my daughters who are informed and engaged, and regardless of what I tell them, will be using Google Health and relying on Amazon for services, who will go to CVS Health before they'll go to primary care. And that's the nature of them. And when they enter the traditional healthcare system, they are expecting to be much more engaged in the decision making. They want to be active members of the healthcare team. And so that is one part of the future consumer. But the other part of that consumer group are really what we call patients. And we are watching the influence of a growing group of very vulnerable subgroups within our population. We have children who are living with obesity, who early in life are developing heart disease and diabetes. We have youth and their families who are confronting the devastating effects of the opioid epidemic, behavioral health issues. We have a vastly aging society, rapidly aging society, and a shrinking family caregiver workforce. And I mean this sincerely. Family caregivers are part of the invisible workforce within healthcare that we rely on tremendously, but as a society have invested very, very little in them. We have people living in communities who are going to have lifespans 20 years less than those living a few zip codes away. So that's just a sense of who the consumers of healthcare are. And within the healthcare system itself, we have places like Penn and Stanford and Mayo and Harvard where you can access the best in innovations and technological advances, a tremendously very informed workforce working as teams. And you can do this, and we have remarkable results. These evidence-based practices that they're delivering are achieving remarkable results. We had a paper released in the last couple of weeks that shows challenges associated with cancer. Not only are we reducing mortality, but we are actually making much higher quality of lives for people diagnosed with cancer. On the other hand, in just a few communities away from here, we have people who have basic challenges in accessing primary care services, behavioral health services, who enter community health systems where they do not receive the same kind of care, and who leave those systems, and there's huge disconnects, fragmentation, and all of that has tremendous human and economic consequences. So that's the kind of picture of the context. So let me tell you where I think there's an opportunity not to bridge those different views, but to kind of make that view of the patient and the people who have very limited access to the services that we need to kind of help rise all boats. The first of them has to do with, let me push back here. Okay, there we go. The first, though, is this notion that we should figure out how to unleash the capacity of all of us working within the health systems. And in particular, within health systems, this really means thinking about full practice authority. Non-physician providers do not have full practice authority in the United States. And yet they are prepared in the most glorious educational programs. Licensure, accreditation, certification is better than anywhere in the globe. Abundance of data that these individuals provide care, in some cases better than physicians, increase access and decrease cost. So the first on the left,
the slide is not there.
it's not there. So anyway, on the left there, that a diagram shows you in the United States 23 states have allowed nurse practitioners to be able to achieve what it is that they have been prepared to do. The remaining states place restrictions, varying levels of restrictions on them. And this, by the way, has major implications for access to care, major implications for the way that we think about delivering services, especially to at-risk populations. But this is not limited to nurse practitioners alone. Dental hygienists are quite restricted in the United States by the profession of dentistry. And yet we know we have 3-year-olds, 4-year-olds, 5-year-olds who are living with dental caries, who are having extractions at ages 6 and 7 that dramatically affect their health and well-being for the rest of their lives. So we need advocacy for regulatory change throughout the United States that unleashes and maximizes on the contributions of all health professionals. We need also a culture within organizations and leadership that say that those individuals are going to be equally valued in the delivery of care. A second theme, which you would have seen a great picture of, is this notion of that we know, even though we need to really say people should do what they can in their roles, that we know solutions to the big health problems we are facing will not happen by any single discipline or even multiple disciplines. Disciplines need to function in teams. We also know that we need to be expanding our definition of teams. One of the groups beyond nurses, the most trusted health profession that is really trusted, are people like medical assistants who are greeting people in the offices. Roy will talk a little bit about community health workers, peers, family members, but I want to talk about the family members. Family caregivers are a group that we invest in very, very little, and yet we've begun to realize the negative effects in all of our respective environments when we don't do that. Presenteeism, where people come and are spending most of the days trying to help mom and dad get the appointments they need. We have people leaving the workforce early or interrupting their jobs, et cetera. States have begun to take this on. States of Washington, Oregon, Arizona, beginning to really say we need to invest in every workplace in family caregivers. Organizations themselves are extending benefits to family caregivers in the form of leave, flexible pay, and even support groups, recognizing that as the family workforce is shrinking, employers need to take a much more active role in this. The third point that I would make is that while most of us think about care delivered in hospitals, where the needs are is in the community. This is where people are really desperate for services. We have an infant mortality rate in this country that is a disgrace. We are 33rd out of 36 OECD countries in terms of infant mortality rate, yet we have evidence-based solutions such as the Family Nurse Partnership. A nurse begins to partner with a family, a low-income mom who is pregnant, and works with them and their children for the first couple of years of life. And the impact of that program for those individuals, for community, and for society has been astounding. We are now watching these children at age 18 who are having much higher educational attainment compared to other at-risk groups, and much greater cost savings for the health system as a whole. So these are examples of the roles that we need to be preparing our future. It's not just the hospital, it's the community that really needs the future of health professions. And my last point is we need lawyers. The kind of work that I do in engaging at-risk older adults and their families is exposing us to the kinds of needs that we can't solve. These individuals are experiencing debt, financial exploitation, abuse, and we know that medical legal partnerships can have a major, major impact on improving the health and well-being of these individuals. Cincinnati Children had a 3-year study where lawyers were in primary care practices doing the kind of work, consulting with healthcare teams who are early identifying problems and enabling them to be able to get the consultation and in some cases full legal representation that those families needed in order to address the health issues that they were confronting. They had an 89% success rate in the referrals within that. So there are huge opportunities as we think about the changes in healthcare and the needs of people related to health that I think say we've got to unleash the capacity of everybody to do what they can. We have to enable them and create environments that allow them to function as teams in solving problems and value the contribution of every team member. We have to think about very different settings for the future of health professions, because that's where the needs are. The needs are not necessarily the greatest needs, and we need to be doing this not just as a group of health professionals or even health and family caregivers and community health workers. We need to be doing this in partnership with you. So thank you.
Thank you.
Sign of a
Seat
true expert.
choice?
Yeah, I have to stand too because I'm too short to sit there. You don't need no stinking slides. I think it's going to be your.
I just had pictures. They're beautiful.
So you'll hear some redundancy in the comments that I make as well. So again, so I've been running the Innovation Center. We've been around for about 8 years or so. We were formed under Ralph when he was CEO. And our goal has really been to think about the transformation of healthcare delivery. How do we get to high-value care models? How do we fundamentally change the patient outcomes we see? And recently, we've worked on over 100 projects now, and we did kind of stop and take stock and say, what can we look at if we look across projects? And this is just a sample of projects that we've done over the last 8 years. And this sample happens to represent successes, ones where we've really materially moved a needle that we care about. Maybe that's readmissions, maybe that's time in the hospital, maybe that's infections, but we've actually seen something work extremely well. And we said, well, what lessons can we learn and can we kind of abstract from the experience going across this work? There are 3 buckets that you typically hear that I think do in some ways capture and reflect at least a part of it, and I'll try to give you some of the nuances behind those buckets as well. So who gets care, who gives care, and where care happens, which we also heard Mary talk about and Ralph talk about as well. So who gets care, first of all? So we all know you have limited resources, and you have to allocate those resources efficiently and effectively. That's not really a surprise. The nuance under that is really interesting. So if we need to find where can we make the biggest difference? Where can our intervention actually create the biggest change in the world? What we've been finding is that there's extreme power in this algorithmic care and algorithmic identification. Where do we pay attention? If you have a population that's a very large population, how do you know where an intervention will make the biggest difference? That could be in the legal profession, which client might you want to work with to make the biggest difference. So a couple examples right under that green box. MEND is an integrated behavioral health intervention that we've recently designed in the hospitals. And it was really fascinating. One of the things, we always knew that we had more people who needed behavioral health interventions than we were really addressing or helping or even finding. The beginning of algorithmic identification, we actually started finding 8 times as many people who would benefit from a behavioral health intervention than we ever found before, which was a good starting point for that intervention. One of the things that was actually interesting there, we'll get into hopefully in the talk, is payment models. Ralph actually was the person who came to us and said, don't really think so much about getting paid for behavioral health or mental health. There's always been this long theory of if you do a better job with mental health, you might be able to do a better job taking care of physical health. That intervention actually cut a full day off of time in the hospital, which is where the economics were, not getting paid for the actual mental health services. So often in business model innovation, you hear things like a 2-sided business model. You have one customer and a different user and a different payer, and that's really what's going on there. Core, you'll actually hear about David Sermon from our team is here. He's going to talk about this in more detail later. But this is really, maybe at this point, the best intervention for patients with opioid use disorders. So you all know we have quite an opioid crisis going on in this country. Again, starting with algorithmic identification, this team was actually able to connect what you'll hear about in a minute in peer recovery specialists. The care team was actually able to connect with, because they were able to find 15 times more people just in the first phase of that project. So really, really remarkable. And under data-driven risk assessments, one of the interesting examples there might be under palliative care, where it's difficult for a lot of caregivers to move to palliative care because there is a sense that I hear from some of my colleagues that they're giving up on a patient who's near end of life. I want to maybe keep trying, keep doing more. In the data-driven risk assessment, what we're able to do with our data science team is actually do a mortality prediction. What is the likelihood of this person still being alive over the next short period of time? And what was interesting about that kind of almost quantitative view of what's happening in this situation is that it changed the perspective of the caregivers from giving up on a patient to actually bold, empathetic care. I'm actually going to have an end-of-life conversation, and I'm going to do a different type of care given what this prediction model is now telling me. So that's a little bit of the nuance under who gets care and how. Under who gives care, one of the things you'll hear a lot about in medicine is top of license, right? You know, like have the sort of the lowest person in some ways on the totem pole do the work, who can do it well and do it cost efficiently. You know, again, we find that that's sort of that doesn't do, it doesn't serve the purposes. It's a little bit oversimplified. So what we're finding in this space are the three things in the box. The first one is what I'd call escalation models. And in an escalation model, an example there might be a person with some kind of rheumatology issue might go to their primary care doctor and be on their way to a specialist. And you know, a specialist is much more expensive, it's a higher cost, and actually there are fewer of them available. What we found in these kind of e-consult or escalation models, of the people who are being sent towards that specialist, only 1/3 of them actually needed to go there. Right? So you know, you end up with a much lower cost, but also what's really fascinating, I think there was fear of, well, wait a minute, you're sending people away from the specialist, you're losing business. Like, how does that make sense? What actually is going on is that now the specialists are still full, but now they're treating the people who really need them, and actually at a higher profit margin, because those people also have, for example, needs for specialty drugs, specialty medications, where the profit margin is better for us. So the people who need help are getting help, and we're actually doing better off financially. And the people who don't need help are staying out, so everybody wins, and the payer and society wins as well. You know, automation, actually I should say on MEND and the mental health intervention, the same kind of escalation model. That behavioral health intervention used to be all doctors, all physicians. Now it's only about 20%. That you've introduced much more nursing work into that mix. You've introduced much more social work into that mix. So it's 80% non-physician now. In automation, you know, can we get to the point where nobody's doing this work? We've been building virtual care team members. You might think of these as chatbots. You can, you know, chat with a robot. So these are clinically trained and deeply clinically trained. So an example here has been in oral chemotherapy, where you know, chemotherapy has moved home, so you're no longer coming into the hospital, which is great. But these are very toxic, very complex regimens. And so somebody gets home and you have very low medication adherence, very low compliance, and you have lots of side effects. Almost 1/3 of these patients end up in the emergency room in a given year. So, you know, all kind of side effects and symptom management needs. And so by putting essentially a SMS, just a texting chatbot in their hand where they can start to text and get immediate answers that were trained by our clinicians, we saw medication adherence go from 50% to 98%. We immediately started seeing people being kept out of the emergency rooms and out of the hospitals. And 70% of the interaction is programmatic. It's robotic. It's not humans. You know, you're taking that off of the humans plate altogether. And finally, and Mary talked about this a bit, novel roles. You know, there's all kind of things that we're seeing that we're excited about here that are non-clinical and non-traditional. In the community health space is one of the ones that's probably the most interesting. Impact is the name of a program that was designed by Shreya Kangovi, and it's really wonderful. It's a complete redesign, complete reimagination of a model that's hundreds of years old, but never had an effective, you know, measurement, never really was effective as a model, frankly. And she completely changed how you identify these people, how you train them, how you deploy them, how you manage them, how you track progress over time. But these are people who came out of the community with a shared experience and shared background as very vulnerable populations. And the impact here of Impact has been remarkable. They recently published that there's a $2.47 return for every dollar invested, which is not something you see all that often. Similar in what you'll hear Davis talk about in the opioid intervention, one of the real strong levers were these peer recovery specialists, people who themselves were in long-term recovery from addiction. And they made an amazing difference. Not only are they very cost efficient, they're extremely effective. They can engage with patients in ways that the physicians say that we just can't do. We just can't have that kind of an impact. And then finally, and Ralph did talk about this, it was really interesting to me. When I came in about 8 years ago, Ralph had just written that article that he mentioned. It was really a seminal article on automated hovering. But yet, despite that article and despite the thinking that was starting in Penn and other places, if you asked most of my colleagues for the next several years, you know, they would have said there's no way we can be responsible for what people do or what happens to them once they leave the hospital. After they leave the hospital, after they leave the practice, after they go back to their house, their job, their work, their life, how can we be responsible for what they do? And I will tell you that that's not the way we think anymore, right? So this idea of automated helping, this idea of staying connected to people over longer periods of time to change what happens is essentially our philosophy now. So it dimensionalizes where care happens quite a bit. Normally where care happens is, okay, let's not do it in the most expensive place. Let's not do it in the hospital. Even within the hospital, let's not do it in the emergency room. We've set up specialty clinics where we can do things more efficiently for hypertension, for actually complications early in pregnancy. We've designed a lot of these specialty clinics that can do things faster, more cost effectively, and actually better. So even within the hospital, you're moving where, but it's not just where, it's also when. Right? So catching things much earlier. We're seeing things we never used to see before. We're seeing them much, much earlier, which means we can act on them before bad things develop. So the when is critically important. One of our signature projects has been a one called Heart Safe Motherhood, where we send at-risk mothers home with a blood pressure cuff, and we start a texting program with them. And because we've been able to do this, we can actually see elevated blood pressures. And so this is in the area of preeclampsia. So it was the leading driver of morbidity, of readmissions, even mortality for this particular maternal group. We have now seen an 80% reduction in readmissions, 80% reduction of people coming back to the hospital, 80% reduction of things like strokes and other morbidity, just because we're staying connected longitudinally and we're able to act in ways that we were never able to act before. It does mean that we have to change what we can do at home. We have to train home care nurses to do different things. We have to be able to, for example, do IV diuretics at home instead of in the hospital if we want to keep people out of the hospital. So there is some changes in what we can do in different sites. And then my final point is, across all of that, we have found we absolutely have to invest in effort reduction. Partially because we have extremely busy colleagues, nurses, doctors, and others. Like there's no room on their plates. There's no ability to do more. They're already working incredibly hard. That's part of it. And so we have to create room on their plates if we want new things to happen. But that's not really all. What you're talking about here is change. And people don't like change. Change is hard. People resist change. If you make change not only easier, but easier than the old way they used to do things, it's actually easiest. Now you can actually have a real impact. And we've been able to actually, in many cases, just dramatically reduce what it takes to do your work. So that's where effort reduction comes in.
Thank you. Well, thank you all. There's so much content and wisdom here that I know has will catalyze a lot of questions. I want to myself ask a few follow-up of each one of you. Mary, maybe starting with you, and you had the map of the states, and this is something that's really similar between our two fields. Yesterday we have here today, and the president of the American Bar Association, Judy Perry Martinez, who spoke yesterday, and as you said, Judy, to me, you're not a regulator, which I had two responses to. One, you kind of are for law schools, right? Through the accreditation function, we care a lot about that group. But however, more pertinently, I wish you were a regulator. I wish that some of these ideas of reform that if we catalyzed and talked at a national level, we could kind of implement with after appropriate discourse. But no, we're working as with your field, Mary, across 50 state capitals. And I wanted to ask you to speak a bit to the kind of way that change happens in that diffuse manner. Now, and then there's something you said caught my attention. I think you mentioned Arizona, Washington.
For the family caregivers.
Yeah. And what struck me, and it'll struck some of us, I think, is that if we were to rank the top 4 or 5 states on legal licensure reform that seemed to be forward-looking, those probably would have come up. And
right.
So
the West Coast, yeah.
So what is it, both generally the phenomenon of working for change at the state capital level, but then is there something distinctive about the political economy or the governance of some of these Western states that makes it, in both of our fields, a fertile ground for reform?
Yeah. I mean, just thinking about the future professions, maybe there's an opportunity for collaboration around these kinds of efforts, because we have been engaged as a profession, and here we're talking about nurse practitioners just as an example. That's a subgroup of nurses. 3.2, 3.3 million, the largest health profession group in the country, and of which an increasing number are masters or doctorally prepared. And so what has been a real effort is to build state coalitions, groups, led by national organizations, but really deliberately coming out with similar messages around, for example, I and others have been involved in synthesizing a robust body of evidence that shows that that we are, why regulations exist. They exist to protect the health of the public. And here there's no evidence whatsoever that those are issues. So we have been working with state coalitions to make sure that everyone is informed about the current body of evidence. We're helping to build advocacy skills within those coalitions and bringing in a really wide table sometimes of people that have been resistant to these kinds of changes to make sure that that kind of messaging has come across. It's, there's been pretty substantial movement since 2010 when the National Academy of Medicine took this on and said the future of nursing really needs to be able to make sure that we remove these restrictions. And so that has been really, really helpful. We've also been, I work in the National Academy of Medicine group to engage people, patients, family caregivers in the advocacy effort because they are tremendously strong voices who can tell their stories about what it's like to be able to receive the care and services of individuals when they need them. So it's been that kind of multi-pronged effort. Federal Trade Commission, we began to work with them. They now have a white paper that is out and now reinforces everything I just told you, which is there is absolutely no reason not to advance. So this is really been efforts trying to figure out who are all the people and groups that we can engage in this. As to why certain states, I mean, we've watched this not just with changes in terms of regulations, as you're describing, maybe there is some parallel groups, but there have been certain states where leadership has really been out there thinking, always forward thinking. And I don't know what the ingredients to that are. Certainly, some of what we see in terms of healthcare is access to primary care is a big driver of willingness to change. Increase rural communities, for example, states with large rural environments know, absent the engagement of nurses and nurse practitioners, they will have nobody delivering services. So I don't know what the ingredients are relative to culture of states, leaderships of states that make them more likely to be doing, but I do know that they have been forerunners in more than just changing regulatory practices around nurse practitioners.
Mm-hmm. Thank you. Ralph, I want to ask you to kind of knit together the first two principles you talked about. Number one, that payment drives change, and number two, that it's difficult to change with professionals. And so this is a question about that came up yesterday about the internal reward and compensation structures within big health systems, or in our field within big legal institutions. At Penn Medicine or Chicago or others you're aware of, I've seen some stuff that Geisinger has done. Yeah. Has there been any success in changing the way physicians and nurses and others are compensated to effectuate this change from volume to value? In other words, can you compensate? How hard is it to compensate for value in a world where traditionally we've rewarded volume of hours, volume of procedures?
As I said, the change has been slow in coming, even though it's been aspirational. But some of this really goes back to the mid-'80s, so it's accelerated quite a bit in the last 7-8 years under the Affordable Care Act or Obamacare. So let me give you two simple stories here. For example, many of you who are from the West Coast have obviously heard about Kaiser Permanente Health Plan. It's a big health plan that covers California and goes up into the Northwest. They are both an insurance company as well as a set of doctors as well as a set of hospitals. And they get, therefore, since the practice is all internal, when you go to a Kaiser facility, you've paid in advance, roughly $10,000 a person or $20,000 a family. Once you've paid that amount of money, it's in Kaiser's interest to not necessarily have you see a doctor. So half of Kaiser's visits are through telemedicine. Because once they've been paid their $10,000 or $20,000, to go back to my earlier analogy, they don't want to run the taxi meter anymore. They don't need to have a cardiac surgeon or an endocrinologist or other people see you if they can. So in that sense, once you're paid in advance, then you start thinking. And same thing if you're paid in an episode or a bundle. If, as I said at Penn, we get paid $30,000 to do a hip or knee. Once we do that, then we don't necessarily want the orthopod or the Mary's advanced nurse seeing that person. If we can do it with a home health aide, if we can do it through telemedicine, if we can do it through other forms of that. So in that sense, you start allocating who does what you're doing through the payment model. Then to go to Ted's point, how does that shape kind of compensation inside? Obviously, we are still market-based, whether you're sitting at Kaiser Permanente in LA or San Francisco or sitting with Penn Medicine here in Philadelphia. If a cardiac surgeon costs X and a neurosurgeon costs Y, that's what you have to pay to compete in the local marketplace. You can't just say, we're going to pay a lot. And even Kaiser has their own set of... So the marketplace still works. You can make some modest changes. By and large, the bigger places tend to be more salaried. So, we don't pay our doctor more to be there on Friday afternoon, frankly, the way private practice works. So you do have some sense of, you set annual salaries, and we've worked very much on that, and to have it tied to teamwork and quality outcomes. So you measure patient satisfaction, not just how many quote-unquote RVUs the doctor has done. So increasingly, you have those kind of measures as to how the outcomes that society, and by society I mean not just patients, I also mean the Medicare agency and Blue Cross, they measure us all the time. So increasingly you try to measure those things as well. It is still a challenge, I would say, to have as much sharing of income as one would have in a more Bernie Sanders type society. So essentially, surgeons still get paid more than neurologists, and they get paid more than primary care. So those kind of differences that have been there for 50 years still there. They're more modulated than they were before, but they are still very much more market-based. So to repeat those themes, one is the payment model will dictate exactly the skill mix that you use. And when you're just paid, quote-unquote, fee-for-service, what I call the taximeter, then you want the surgeons and neurologists and the primary care people seeing people. That's how they get paid. Increasingly, we're moving away from that. So therefore, once you get paid in advance, the extreme is a kind of Kaiser model, where you're both an insurance company, and Geisinger, which is a system here in Pennsylvania, does the same. They're an insurance company as well as a set of doctors and hospitals. So once you're paid in advance, it does change. That is still a very difficult model to create in most parts of the country, and most people who try to do it without growing their own, creating their own doctors, their own nurses, and so forth, have failed at it. It's just a skill set that's hard to do. Secondly, the more and more you put people onto annual compensation, as opposed to having a high differential in incentives, it does start shaping behavior in different ways. And third is, I'd say, the marketplace still works. So efforts to pay people more equally based on years of service, the kind of civil service system and so forth, really has not come to medicine yet. There's still differentials based on the marketplace. So we have to compete against, the Harvards and the Dukes and the Hopkins and the Stanfords and so forth in terms of professional talent. So you have to be responsive to that. But on the other hand, for example, we are both in Princeton and in Lancaster, to go back to my Phillies example of this, or Phillies fans are. So the Lancaster market and the Princeton market are a little different than the Philadelphia market. So you take advantage of some kind of local variations.
Thank you. Roy, what's distinctive about your really impactful career is that you've worked in such different settings. So the kind of huge and established medical system for the last several years, but then this kind of quintessential or what is perceived by those of us who don't live and work there as the quintessential innovation hub of Silicon Valley. I ask this as somebody who's spent more hours in my life watching Silicon Valley, the show, than actually resident or president of Silicon Valley. So the caricature, I want to invite you to kind of complicate or put nuance on. The caricature would be, Silicon Valley, your role is, there's just so many ideas, your role is almost weeding out most of them and getting people to focus on task. And then in the more established medicine like law, you're trying to get people to think creatively. Is that story too simple? And how would you complicate it for us?
Yeah, I think it is. It's an oversimplification. But so what's true is that it's a wonderfully active ecosystem. It loves problem solving. It loves novelty, sometimes, unfortunately, for novelty's sake. But You know, the thing that ties these two together is this sense of what's taken over Silicon Valley, what we're trying to infuse through medicine, at least Penn Medicine now, is this idea of extremely rapid experimentation and validation, which means that you can get into creative problem solving, but you can do it safely if you're driven by a hypothesis and you design an experiment to test that hypothesis. So really what's happened in Silicon Valley is a compression of cycle times. I go much faster in cycles, experimentation cycles, and I can go much faster and much cheaper based on the kind of methods we use to test whether I'm right or whether I'm wrong. So I have an idea for a new product, a new service. How are you going to figure out if you're right or you're wrong? You know, I'll vapor test it. I'll take an image. I'll computer generate an image. I'll put it on a website. If somebody tries to buy this thing that doesn't exist, I'll say it's out of stock. And I learned whether people ever click to try to buy it or not, right? It's contextual demand testing. There's a million ways to do these things in healthcare as well, all safely. Certainly there's more conservatism, for sure. But what we found is that we can craft techniques and experimental methods that are safe and allow us to have a similar cadence where every week or every 2 weeks we have a new version of what we're trying to do that drives change. And there's no doubt, I mean, just to build off what Ralph was saying, payment model change almost enables us to exist, right? Us being the innovation world. You know, some of my favorites recently, Ralph talked about lower joint bundles. You know, as soon as we have lower joint bundle, now we have the remote monitoring that we both talked about. You know, now I'm tracking people when they go home, and we've cut more than half of readmissions out of that, right? So you get to experiment because something has changed. My favorite one recently is in breast cancer and breast reconstruction. They went to a global payment, so you get this fixed amount of payment. You know, it's again just building off of Ralph's comment. Fixed amount of payment in the 90 days post-surgery, right? So in the old days, you'd come in 5 times or 5 appointments, right? And we actually just had an innovation where we've eliminated 4 out of 5 of those appointments, right? In the old world, if you eliminate 4 out of 5 of your appointments, you've lost 80% of your income. But in the new world, you're getting paid a fixed amount. Your goal is to keep women safe and to make sure they have a good outcome. As long as you're doing that, you've actually created massive new economic opportunities because you've opened up all these clinic visits. So now 4 of those 5 have gone to home care, have gone to the remote, you know, let's just text pictures back and forth and let me make sure you don't have an infection on that site. Get rid of all this work that's unnecessary work because I'm not getting paid to do work anymore. So what's making it a little bit more like Silicon Valley is actually breaking this old hold of the old way of getting paid where you can actually do better by being creative. Right? In the old model, if we were creative, we did the Silicon Valley thing, we experimented, we changed, we got better, we would lose money.
Do you, just a follow-up for you or any of you, so that's an important point in it. It's as we think about legal change, when you take fixed payment, you're taking on some risk.
Yes.
So, and you're almost performing an insurance function, or at least you're insuring around the variability in the cost of the legal service. That do you have to be big to do that? I mean, it's a question that, or how big do you have to be? Because
yes and no. In part, the bundles, the episodes, these clusters have been more around defined procedures. So in kind of simple graphical terms, it's more around surgery than the kind of cognitive specialties where there's a lot of variation. So basically, in kind of statistical terms, when there's not a lot of variation, you can do a bundle more fully than when there's an enormous amount of variation. So by and large, the bundles and episodes have not gone to fields like diagnosis of MS and autoimmune, when there's, you can have a very simple case, a very complex case. Whereas, frankly, replacing a knee is replacing a knee. I mean, even though you get a hemophiliac or something like that, but by and large, it's more of a defined operation. So in that sense, if you're going to take, in the insurance jargon, if you're going to take incidence risk, meaning is Amtrak going to crash in North Philly and have 10 trauma patients come rushing into your hospital, you're going to take the risk on that. In each case is $200,000, maybe not. If you're an employer that has 20 people and one of the people has premature twins that cost a couple $100,000 each, you don't want to probably take that kind of risk. And therefore, you probably want 2 million people, to pick a number, to spread the risk of a Amtrak crash in your backyard or premature twins. We're increasing what we're finding right now with the opioid epidemic inside this country. For example, when you're a substance abuser, your heart valves get reasonably clogged up and so forth. We get paid, a heart valve case is based on come to the hospital for 5 days. The people who are substance abusers may be in there for 40 days. Do you want to take the risk if you're in West Philly, as Penn is, on all these substance abusers coming in, having to be in the hospital for 40 days. So you can see you probably want a big population before you take that kind of risk, as opposed to more limits. So essentially, one of the reasons I've not got directly at Penn into becoming an insurance company is many people as we see, we don't have 5 million patients. And so basically, you want to have millions of patients to spread that risk on whether it's liver transplants or train accidents or premature birth and so forth, as opposed to. So I think a lot of places, and my counterparts around the country, have gotten into big trouble, Hopkins, Mass General, and so forth, by taking on risk without necessarily having the scale. And those are big places, so that tells you have to be pretty big.
And they're bigger than even the biggest law firms. So I mean, it's an important topic for our field about this notion of changing payment and taking on risk. I want to. We have 10 or 15 minutes left. I want to invite questions from the audience. Yes. Well, I see a few. I see at least 3. We'll go here, and then here. Okay, 4.
Good morning. That was really illustrative and beyond. But I wanted to ask you about federally qualified healthcare centers, because they are a congressional allocation to kind of create the equivalent, I don't know if the analogy flies, but of legal services, right? Those are healthcare facilities, community-based clinics that are there to help the people that will not qualify for Medicaid, migrant workers, the uninsured, and things like that. They're not hospitals, they're clinics. And they tend to be generally located mostly in either certain zip codes or really rural areas, like where I live. My question to you is, are your systems and your innovations overlapping or interfacing with federally qualified healthcare centers, which would be the equivalent of legal nonprofits funded by the federal government, to help with some of these innovations, like with the community-based practices, with the helping people take care of themselves at home when they're in very remote rural locations or very snowy areas, etc. Just the overlap between your big urban centers, your innovations, and then infrastructure that exists specifically for the very low income and uninsured.
Mary, do you want
So first of all, the federally qualified, thank you for that question. The federally qualified health centers are a major contributor in the evolving healthcare system, and with the Affordable Care Act got quite a boost in terms of increased investment. So just so that you know, the work that we do here at Penn, while we obviously have a major partner in the University of Pennsylvania health system, is about changing healthcare delivery across the country and across the globe. So we partner with federally qualified health centers to really think about how to extend the work that they're doing and make sure that it's guided by evidence-based practice, the best use. Many of these federally qualified health centers are, in fact, led by nurse practitioners. So just to give you an example, we're working with a group that is helping them to think about how to extend the work that they do in the health center into the home, enabling the nurse practitioners to be able to follow people who are at risk into the home and prevent them from ever having come into a healthcare system. So that's the way in which the kinds of innovations and evidence that we're producing is being used both to help existing very important infrastructure in addressing the needs, health needs of our nation, but also extending the contributions that they can make.
Let me make both at Penn and Chicago. First of all, we staff one about 10 blocks from here. And as your question implies, having doctors, nurses, social workers, everything under one roof is helpful. But let me speak to one that we have downtown in Center City. Based on your political preference, it either serves undocumented or illegal people. So basically, this serves the Mexican people who work in the restaurants of Philadelphia. None of them have insurance. And what we have in there, we have doctors, nurses, social workers, lawyers, and so forth. So we have law students and social workers who help them get driver's licenses or apply for public housing or just deal with the activities of daily living in addition to giving them free medical care. And so it's a great model. We do it basically for free, but we have good altruistic people who want to be medical students, young lawyers and doctors and social workers at Penn, and we staff that totally for free. I did the same thing in Chicago. our emergency room was just being overrun. University of Chicago, for those who know Chicago, in the south side of Chicago, which is a kind of combination of West Philly and North Philly. And so basically we set up a FQHC, Federally Qualified Health Plan, 2 blocks from the hospital to keep people out of the emergency room. And we staffed it with all our staff. It gave people great access to care. And by the way, we got paid twice as much per unit as we got paid by Medicaid. So instead of hemorrhaging on Medicaid, we were actually able to break even on doing primary care. So one of the advantages, what one learns in the kind of role that I've had, is there's a lot of opportunities inside the federal payment system to get paid for people who are poor. And you have to figure out how to tweak that to make sure. And one of the things the Penns and the Chicagos all can do is figure out, it's like the Mr. Trump's version of tax loopholes. There's a lot of ways to serve the poor if you figure out what the federal system is. And one of the things that Penn can do very well is get access to those funds to take care of the needy.
Mm-hmm. Yes, we have time for a few more.
Hi, I have a medical education question. So I'm a law professor at Brooklyn Law School in New York, and I've been curious and really trying to study how the medical profession has been directly addressing as part of the curriculum things like student fear or anxiety or stress or vicarious trauma, or how to have hard conversations with patients, or financial strains about some of the things that we've been talking about. And based on my research, at least, it seems like medical and nursing education have been making innovative strides in that curriculum area. Even the Silicon Valley example of just allowing students to make mistakes, but in a safe environment, in a low-stakes environment, so then when they get out in real practice, it's not as high stakes. So I'm wondering if you can talk at all about those educational initiatives, and if you think they're effective to prepare med students and nursing students for the realities of practice and having well-being in the profession.
Mary, can you?
So I'll start by, thank you again. That's really important, is how do we have, and this is, I don't think unique to medical students or nursing, but law students, how is it that you position them to really optimize, build the trusting relationship, enable them to be able to help you understand what their needs are. So we use, for example, a lot of simulation as a strategy, and that also is a very big part of the medical school education. So the opportunities are first to create the comfort level within the trainee, the nursing student or the medical student, and then gradually introduce them to the kinds of interactions. But there's a lot of oversight. I mean, with all of the wonderful work that's coming out of Silicon Valley or the Innovation Center, at the end of the day, it's about relationships. It's about the kind of trust that people have with each other that enables us to be able to really optimize our contributions. Interestingly, we are being called on, I don't know about the medical school, but the nursing school, we're working with groups like Bank of America, Merrill Lynch, to help them think about how their financial planners can better establish relationships in order to be able to maximize on what they're hoping will not just be a relationship with the person with whom they're working initially, but ultimately a family, a long-term relationship. So there's a lot of cross-fertilization opportunities that we have. I think that here at Penn, we try to really maximize on those linkages, but I think that maybe we could spread ourselves into other fields and make contributions as well as learn from how it is that you do it that could enhance our work. So did that answer your question?
Well, one thing, one thing we've learned is that people need training all the time. And this notion that you get trained as a law student, a medical student, that kind of stays with you for life, I just don't believe that. So just like there's this whole, you can get YouTube now on almost anything in your house and so forth. So one of the things we've tried to do at Penn, and we have an enormous internal training academy, which is called the Penn Medicine Academy. So basically, you want 30-second snippets here and there to remind you. So when, obviously with the coronavirus going on right now, you may have been trained on how to deal with infection 5-6 years ago as a nurse, but you want to remind yourself to do a little 30-second snippet. This is what you do. Here's your checklist and so forth. So that kind of technology now, when 30 seconds here, 3 minutes here, you can remind yourself of what to do, whether it's around infection, whether it's around control, how to discharge a patient to home, whether it's around billing and so forth. Just a little refresher, so we have that all the time. One of my phrases I always use is, if Roger Federer can have a coach, he's the world famous, we can all have a coach. So the notion that you only need to be coached when your remediation is wrong. So everybody can improve their backhand, so to speak. So we coach people all the time, and we try to make it easy by saying 30 seconds here, 1 minute here, rather than come see us for a month. So that sense, I think, that's much more powerful now than it used to be.
Yeah. And Roy, is that something you view in your jurisdiction as an innovator, like about kind of HR issues and supporting the employees,
For
doctors
sure.
and nurses?
Yeah, I mean, both because I think there are technologies that matter. You know, simulations are great techniques. You know, AR, VR simulations can be even better, right? You know, because they can get you more in a more realistic scenario. You know, we layer on technology carefully because I agree with Mary that it's ultimately it's a human relationship. You know, when I talk about automation, I mean for the things that robots can do well, leaving for humans the things that humans do well. You know, so certainly we look at this quite a bit. We also, you might not think of it as training, but you know, Ralph and I spent a lot of time on the health system side also building a group called the Nudge Unit, which actually is about behavioral science. And as opposed to training, it's structuring an environment in which the right thing tends to happen even without the training, right? You know, changing the defaults, changing the way information is presented, how, when, et cetera. And you know, what we've found is we can actually move needles tremendously by re-architecting the environment, not the human always. And I think that's extremely important.
Yeah. Thank you. So we have a few minutes. A couple people have been waiting to ask. I know you have, and then this guy. And one more minute? Yeah. Well, okay. Let's try to get to the two questions who've been waiting for a while, and we won't get a quick question. We'll have one quick answer, and then we'll come down here.
So, quick question. I'll go quick. I was going to say, first of all, great presentation. So many similarities. You know, I wanted to ask Ralph, you were talking about the fact that you had looked at self-insuring or insuring the population in the area, but that the sample size was too small. And I was wondering to what extent, you know, hospitals might be able to work with other hospitals or the insurance industry to lay off that risk into the secondary market in some way, or if some secondary market could be created in order to kind of solve that problem.
Yeah. Well, could hospitals kind of cooperate? First of all, there's antitrust reasons that get in the way of kind of sharing prices and so forth. So that's almost so dispositive. You really can't share prices with others. In some ways, that's what insurance companies are for. Now, as Sanders and Wars, others point out, they're a little bit too expensive. There's things one can do without going to Medicare for all, which I think would be a big mistake. So it's not the purpose of today's conversation. But one can lower those kind of costs. But I think by and large, employer coalitions and so forth, frankly, don't work. I think it's, people try it, but by and large it doesn't work, and getting people to cooperate has all kinds of antitrust problems.
Okay. Yes, last question.
Yes, so my name is Tanina Rostein. I teach at Georgetown Law Center, and I should mention that for many years I thought of myself as a legal tech innovator, but now I know it has to be in air quotes, having heard from this panel. So my question has to do with the financing model and Ralph's observation, and the rest of the observation that economics drives organizations of practice and innovation within different professions, and also follows up on Mary's description. The last thing you talked about is the need for lawyers embedded in healthcare provider settings in order to provide other services, and in fact create better health outcomes because of legal interventions. So is there a conversation going on in either the public insurance or private insurance space about actually using private or public insurance to subsidize lawyers in those settings? In other words, there's beginning to be some conversation / evidence about laws of social determinant where they're all, and that's a bigger movement in medicine. Is there is that conversation beginning? Is there a place for that conversation to continue?
Yeah.
So I'll start. I think that the Bipartisan Budget Act of 2018, which has housed in it, it's the Chronic Care Management Act, it really talks about thinking about how, and for Medicare Advantage patients, which about 31% of Medicare beneficiaries are in the Medicare Advantage program, and that's expected to grow pretty exponentially in the next couple of years. What they're doing is trying to say, tell us what's needed in terms of health or social services in order to get to better outcomes. And I think that is unleashing, if you will, the capacity to think about a whole different team delivering services. So they are saying, you know, if we need X, if we need housing support, if we need help in getting people to get benefits, and there are barriers to that, how are we going to address it in order to make it happen? So I think at the federal level, in Medicare Advantage is a good example of where we're seeing some opportunity to play out and where innovation, I think, could abound.
Yeah, I think it's demonstration projects. Like nothing succeeds like success. So you're seeing these emergent things. An analogy is putting people with tax preparation in emergency rooms, right? You're seeing it in a couple of places emerge because an inordinate number of low-income people don't claim their low-income tax credit. It's $3,000. The difference between a healthy diet and an unhealthy diet is about $500. This is $3,000, right? You know, so you're seeing you can actually get people $3,000 just by doing quick tax prep in the ER. So I think demonstration projects and create emergent strategy and policy.
So I'm going to, this could keep going. This is so enriching. And I want to thank all three of you. Our next panel actually continues some of this discussion, and we'll hear from an innovator, another Penn colleague, about addressing the opioid epidemic and continue these themes. But we have learned so much. We have so much we can continue to learn from all three of you. Thank you for your participation in this effort.
Thanks for having us.